common intraoperative complications that we face in OR are the periprosthetic fractures, the limb length discrepancy, the instabilities, and the neurovascular injuries. So coming on to the periprosthetic fractures, the acetabular fractures are not so common. The incidence of cemented cup fracture, acetabulum in cemented cup is 0.2%, and in non-cemented cup it is 0.4%. The host factors that are responsible for acetabular fractures are severe osteoporosis, female gender, and the rheumatoid patients. While the technical errors that are responsible are the, if we underream the acetabulum by more than 2 millimeter difference between the reamer and the cup size, it may lead to the fracture. Overzealous and the eccentric reaming can also lead to fracture, and massive force at impaction, especially in the osteoporotic bones. Also, Dr. Pachore told that certain designs of acetabular cup, like elliptical cups, when they are used along with the spherical reamers, in order to get a more press weight, such cups may also lead to the acetabulum fractures. The classification is type 1, which are undisplaced fracture, and the cup is stable, and type 2 is a displaced fracture, and the cup is unstable. The medial wall fracture was the most common pattern, followed by the anterior column, posterior column, and the transverse fracture. So this was the X-ray. The fracture was detected intraoperatively, and but the cup was stable, but it was reinforced with 2 screws, and patient was kept on the non-weight bearing for 6 to 8 weeks, and patient was bailed out of this situation. This patient probably had a displaced fracture, but the cup was used and supplemented with the screws, and the patient was kept for non-weight bearing for 2 months. And then when the patient was started giving the weight, there was a gross intrapelvic migration of the acetabulum implant. At this time, I received the patient. A CT scan was done, which showed the fracture of the posterior column, and plating was done along with the tantalum cup revision was done in this case. This acetabular fracture was detected in the recovery room, in the post-operatively, and the fracture was anterior column was there. So it's always better to see the fracture before it sees you. CT scan was done, and it was treated non-operatively with 8 weeks of non-weight bearing with a favorable outcome. This is the X-ray at 1 year of follow-up. So intraoperative suspicion of fracture and recognition is very key to success. If you have a doubt intraoperatively, palpate the peripheral limb, palpate sciatic notch. If in doubt, remove the cup and assess the bony bed, and also you can take the help of intraoperative fluoroscopy. The femoral fractures are much more common. The incidence in certain articles are more than 5%, and in revision cases maybe up to 20%. So if you feel any sudden change in resistance while inserting a stem, it should always raise a suspicion for a fracture. In such cases, it's better always to use the intraoperative fluoroscopy and define where the fracture is. And it's better to expose the distal extent of the fracture. If it is not exposed properly, then such complications are inevitable. The most common complication is the Vancouver classification, which basically depends on the location of the fracture, pattern of the fracture, and the stability. So it's divided into type A, B, and C. Proximal metaphysis, B is the fractures around the stem, and C are the fractures distal to the stem tip. So the most common fracture, intraoperative fracture, is calcar fracture. And once you see the calcar fracture or greater trochanter fracture in the OR, always fix it with the wires. The wiring technique is not so complicated. Always pass the wire, try to pass the wire just proximal to the lesser trochanter, because lesser trochanter acts as a buttress and prevents the cable from migrating distally and maintains its tension. Cable should be passed underneath the vastus lateralis, and before tightening the cable, always remove the broach or prosthesis. And once you have done the tightening, then you again start with the 1 or 2 millimeter smaller size broach and proceed further. Similarly, the greater trochanteric fracture, Dr. Pachore has described his technique. You can take a figure of 8 also, one arm beneath the lesser trochanter and one in the gluteus medius. If your chunk is very big, greater trochanteric, you can also use the hook plate and fix it with the cables. The type B fractures around the stem, basically, they are very critical fractures, and usually the stem becomes loose. These are unstable fractures. But if the fracture is not migrating distally, you can use the same stem with the encirclage wire. But the fracture, if it is progressed distally, then it's better to remove the stem and use a distal fixation stem. And the fracture can be treated either with the encirclage wire, or you can use the plate if there's a displaced fracture. The type C fractures are basically distal to the stem. The main concern here is the fixation of the proximal fragment due to the presence of prosthesis, where we can use the cables or we can use the unicortical screws. And always try to span the plate as much as possible from the trochanter to the distally to the condyles. So prevention of the fractures is always important. You should anticipate the fracture in high-risk patients, and preoperative templating and planning reduces the chances of fractures. And if in doubt, use the intraoperative imaging. Always when you hammer the stem, you see that your stem is progressing distally inside the canal. If it is not, you should stop hammering it. And also you should feel the sound of the, while hammering the stem. Suspect the fracture if the component goes deeper than the broach, and then expose the entire fracture. The another most common complication is the limb length discrepancy. It leads to the increased morbidity in the patient, anger, frustration among the patient, and many times you have to revise the surgery. And it's the most common cause of litigation in the Western world. Prevalence is very common, but is difficult to quantify. And over-lengthening is more common and less tolerated than residual shortening. In general, it has been shown that up to 10 millimeter of limb disparity may be well tolerated by most of the patients. If the lengthening is more than 1.5 centimeter, it is usually associated with the backache, uncomfortable gait, and nerve palsy, compromising an otherwise excellent outcome of the hip arthroplasty. The etiology are basically two types. It may be a true limb length discrepancy, or it can be apparent limb length discrepancy. And the management and prognosis differs in both the types. The functional limb length discrepancy is more common, and it resolves with the physical therapy. Avoid revision operation and reassure the patient by once you recognize that the limb length discrepancy is due to the apparent reason. There are various measures to measure the limb length intraoperatively. The most common method that we use is the leg-to-leg test. And either you can take a fixed bony point on the iliac crest and one on the greater trochanter. You measure the length before dislocation, and then again measure it after the trial component. And this is a skin suture technique which are described by Dr. Bose. Basically in the anterolateral lateral approaches it can be used. Now coming on to the nerve injuries, it's one of the most devastating complications that we face. There are four ways that by which the nerve injury occurs: the compression, stretching of the nerve, ischemia, and complete transaction of the nerve. The superior gluteal nerve is damaged basically during the lateral or anterolateral approach, and it is at risk when 3 to 5 centimeter of safe zone proximal to the greater trochanter is violated with the direct lateral approach. And once it is damaged, the patient will be having the positive Trendelenburg gait. The lateral femoral cutaneous nerve is basically damaged with the direct anterior approach, and patient complains of the numbness in the anterior thigh. It's a very informative study that was published in Journal of Arthroplasty, which showed the position of the retractors and the distance from the neurovascular structures. So anteriorly, the distance between the anterior retractor and the femoral neurovascular bundle was found to be 2.2 centimeter. And as you proceed inferiorly, the distance was reduced to 0.95 centimeters, antero-inferiorly. And posteriorly, the distance between the retractor and the sciatic nerve was found to be 1.75 centimeter. So we should be very cautious using the retractors and try to use the retractor along the bone only. The sciatic nerve injury is the most common injury, nerve injury during total hip arthroplasty. And diagnosis is made by the clinically assessment when there is a weakness of ankle dorsiflexion. And these electrophysiological studies helps us to determine the level of the injuries. If no specific cause is identified, no immediate treatment is indicated. These studies basically help in measuring the level of injury, what is the degree of injury, and the evidence of recovery of motor function. If intraoperative transaction of nerve occurs, an attempt to repair is warranted. The motor deficits can be managed with the physical therapy. Orthosis can be used to treat the foot drop, and the nerve pains, neuralgic pain can be treated best with the antidepressants and repeated sympathetic nerve blocks. So nerve injury total hip is not so common, occurring in 0.6 to 3.7% of all the patients who undergo primary hip arthroplasty. The peroneal division is most commonly affected. There is no strong evidence favoring one approach to reduce the nerve injury. Lengthening of 4 centimeter predisposed to the nerve palsy, and complete loss of the nerve sensation or severe causalgic pain carries the worst prognosis. And to the most important, no amount of preoperative discussion or postoperative counseling decreased the high degree of dissatisfaction that was expressed by this patient. So to summarize, intraoperative complications are inevitable part of any surgery. Anticipating the problems helps in reducing the event, and understanding the treatment strategies helps in optimizing the treatment outcome. Thank you.